Hi, everyone. Welcome to today's Research America Alliance discussion. I know a number of people are logging on right now, so we'll just pause. I can see the participant numbers ticking up. Thanks so much for joining us on Zoom today, and always for your partnership in the Research America Alliance. We invite you to stay as our guest if you're not a member of the Alliance, if your organization is not a member, but please get in touch with my colleague Joel, whose email is in the chat, and he would be happy to talk with you about all the terrific benefits that come with being a member of the Research America Alliance. So today we are joined by a trio of policy experts from the Infectious Diseases Society of America. So I'm joined by Amanda Jezek, who's the Senior Vice President of Public Policy and Government Relations, Lisa Cox, the Director of Government Relations, and Eli Briggs, Director of Public Policy. For those of you who aren't familiar with IDSA, it represents over 12,000 infectious disease physicians, scientists, and other healthcare and public health professionals who are on the front lines of pandemics and outbreaks, and also help combat other emerging infectious diseases. Today's our topic is antimicrobial resistance. Where are we in the fight against this major public health challenge? How has our fight been impacted by COVID? And what are some of the latest lessons learned? So as always, please type your questions into the Q&A and we will get to as many as we can. So to get us started, let's start with some basics. Some people use the term antibiotic resistance, but that's not really correct. It's antimicrobial resistance. Lisa, can you explain what antimicrobial resistance is on a scientific level? Or Eli, whoever wants to take that one.
Sure, I can jump in there. And thanks so much for having us today. So antimicrobial resistance, we use a broader term because it isn't just about antibiotics, although that is a big part of the problem. And it really just refers to the ability of microbes to change and to become less susceptible to the treatments that we try to use to combat the problem. So it can be either antibiotics, a fungus, or other types of microbes that just are out of control and not able to be treated with the normal course of medicines that we would normally use, and then become increasingly resistant to different types of treatments. And just a reminder for this audience, folks may already be aware, but we're talking about almost 3 million infections each year and more than 35,000 deaths each year in the US.
So 3 million infections that are not responding to treatment. Is that right?
Correct.
And how has antimicrobial resistance, or AMR, been impacted by COVID? What's been the result of COVID?
So the COVID, this is one of the additional downsides of COVID, as if we needed more. The pandemic itself was bad enough, but then there were other things like the AMR situation that became really much worse during the pandemic. And we saw CDC does really great surveillance of these infections, and has reported that in the first year, in 2020, the first year of the pandemic, there were, after years of going in the right direction, we started to see increases in AMR in a number of different pathogens starting in 2020, and we'll see if those trends continue as more information is released. But antifungal resistant threats also increased in 2020. And there are many different reasons for this. One, if we think back to 2020, we know that hospitals and the healthcare personnel were just stretched so thin and weren't able to do their day-to-day jobs, where everything was being thrown at COVID. So that meant that antibiotic stewardship programs really had to take a back seat. And those are programs where infectious disease doctors and others really try to make sure that antibiotics are only used when they are needed, when they are effective, and for as short of duration as possible to try and address the challenge of AMR. So those programs really had to either slow down or shut down. And there was increased antibiotic use during the early days of the pandemic. From CDC has reported from March to October of 2020, almost 80%. So the vast majority of patients who were hospitalized were receiving antibiotics. And that was really whether they needed them or not. So that's another piece of the puzzle. There were people who were staying in the hospital longer. There was increased use of catheters and ventilators, which could have had an effect on infections. And also, if we remember, lack of personal protective equipment, lack of lab supplies, testing of specimens really slowed down in the hospital. So in many cases, clinicians didn't necessarily know what infections were spreading. So all of these sort of were a snowball effect of turning the numbers in the wrong direction during COVID.
And are we now starting to get back to where we were pre-COVID?
We will have to wait and see. We don't have those numbers yet. Our members are telling us is that it isn't just flipping a switch and you can go back.
Right.
Obviously, we are going to have to make an uphill climb back to where we were.
And Amanda, I watched you shake your head. Did you want to add to that?
No, I think Eli was exactly right. And the CDC even predicted that as the pandemic does hopefully start to wane, these numbers will not just automatically come down. We need real sustained direct investments in addressing AMR specifically to bring those rates back down.
So what is the role of antimicrobial resistance as we plan for a future pandemic or another public health emergency I'm thinking of the reauthorization of the Pandemic All Hazards Preparedness Act, and I understand that IDSA is involved in that. Can you talk a little bit about where your work fits into pandemic preparedness?
Absolutely. Well, I think the situation that Eli described with COVID, unfortunately, we would expect to see that happen again in any type of emergency in which hospitals are overwhelmed and in which patients are very sick, because we know that very sick people are just more susceptible to these secondary infections, and use of ventilators in particular can increase someone's risk of getting one of these secondary infections. But I think it's also important to remember AMR is not just an issue for outbreaks and pandemics. We need to think about preparedness much more broadly. Think about hurricanes and other natural disasters. They also increase the risk of spread of infection, including resistant infections. So the loss of electricity can increase the risk of food spoilage and foodborne illness. Interrupted access to safe water and interaction with floodwaters increases the risk of waterborne pathogens. There were actually studies done following Hurricane Harvey in the Houston, Texas area that found dramatically increased levels of pathogenic bacteria and antibiotic resistance genes in the floodwaters and in the soil. And those stayed in the soil even long after the hurricane. So there are long-standing effects here. When we think about wildfires or other types of fires, burns can very easily become infected. So that's another real area of risk. And then finally, I think the other big area of preparedness is, of course, bioterror. And it would be, unfortunately, all too easy for someone with ill intentions to weaponize an antibiotic-resistant bacteria. And so as we think about preparedness, making sure that we have an arsenal of antibiotics that work against these resistant threats, and making sure that we have the healthcare experts who know when and how to use those antibiotics, those are, from our standpoint, central to preparedness.
So thanks, Amanda. So Lisa, I'm going to turn to you to talk about the practice of medicine. So Amanda talked about making sure we have experts who know when to and when not to prescribe antibiotics and what to do when they're faced with a resistant infection. Can you talk a little bit more about clinical care and where that stands right now with AMR?
Sure, and thanks once again to everybody for participating in the webinar and for hosting us. Many of the same ID physicians and professionals who deal with AMR in pandemic preparedness are the same physicians and clinicians who deal with AMR in clinical settings. As one of our members once said to me, her hospital cannot make it one day, one night without effective infection prevention and antibiotics. Essentially, they're essential to the practice of medicine, and they help leverage the many advances in modern medicine that we've seen over the past 50 to 60 years. AMR is incredibly concerning, particularly to patients who are immunosuppressed. So that means cancer patients, people undergoing transplantations. AMR plays a role in opioid use. There are drug-resistant infections that can come from injecting drugs, including skin infections, endocarditis, which is a serious heart infection. And so AMR really sort of threatens the ability of the medical community to make sure that patients who are treated for and may, have overcome a cancer diagnosis don't have a secondary drug-resistant infection that they can die from, and unfortunately, that happens in some cases. In fact, drug-resistant infection is the primary or an associated cause of death in 50% of patients with cancer. So AMR is a serious issue when it comes to clinical care, and really we need to redouble our efforts to successfully combat this issue.
Thanks, Lisa. In other words, it impacts potentially all patients.
It really does. Time. Yes.
So let's turn to the PASTEUR Act, which is something that I know IDSA and many other partners have been working on for quite a while, and it came very close to being enacted, but not close enough. But I know that there's still a lot of work being done to get it over the finish line. There's been some criticism of the idea that we need to incentivize antibiotic development. I see that as like a market failure. You're asking that there be an investment in something that may or not be needed. But perhaps you could talk more about those provisions in PASTEUR to incentivize antibiotic development and production, and then also some of the other key provisions.
Absolutely. So, Jenny, I think you were exactly right that we're dealing with a market failure when it comes to novel antibiotics that can treat resistant infections. And I can empathize with folks who feel like they just don't want to have to give money to the pharmaceutical industry to make this happen. But the alternative is simply not having the antibiotics that we need to drive modern medicine and to deal with public health emergencies. And I don't think that is an alternative that any of us would find acceptable. So the reason that we need this incentive is because antibiotics just really don't have an opportunity to earn a return on investment on their own with the current way that we pay for drug development in this country. We primarily pay for drugs based on volume used. And with antibiotics, we know that the more you use, the more quickly resistance develops. So we need to use them as infrequently as possible. You layer on top of that, antibiotics are typically used to treat acute conditions, acute infections. So they're used for a pretty short time frame as compared to drugs that treat chronic conditions that can be used for many, many years for an individual patient. So because of that, when new antibiotics come to market, there's really the earnings for these drugs are very small. And we've actually seen some of the small companies bringing new drugs to market filing for bankruptcy shortly after they get their product to market. So what the Pasteur Act would do is fundamentally change the way that we finance antibiotics in this country. We would pay under the Pasteur Act for the value that antibiotics bring to society rather than paying for the volume that's used. And so what that would look like is the federal government would be able to enter into contracts with these novel antibiotic developers and pay a set negotiated fee for a steady supply of those antibiotics, regardless of how much or how little of those antibiotics actually get used. So it provides that predictable return on investment that is essential to kind of fuel antibiotic innovation to make sure that that these companies and their scientific experts can keep going, keep developing the antibiotics that we need in order to keep pace with, or ideally stay ahead of, the resistance threats. I think it's also important to note that the Pasteur Act is not just about drug development. It is absolutely also about making sure that these antibiotics get used appropriately. And so we know that stewardship programs, antimicrobial stewardship programs in healthcare facilities are very effective at driving optimal antibiotic use, reducing resistance, improving patient outcomes. But a lot of healthcare facilities don't have the resources they need to fully implement these stewardship programs and all of the protocols that go with them. So the Pasteur Act would provide funds through the CDC to help support these institutions' stewardship programs, with priority given to rural hospitals, critical access hospitals, and safety net hospitals, because we know those are the areas that are really the most in need.
Very good. Thank you. What are the prospects for the bill? Eli, is this something that might be included in the reauthorization of the Pandemic All Hazard Preparedness Act?
Well, we certainly will be pushing for that, and we think that it has a good chance. We built a lot of momentum last Congress. We had more than 70 co-sponsors for the bill, and bipartisan, I would add. And we're hoping to have a bill reintroduced soon. But we really feel, as we've all discussed, we feel like AMR is central to public health emergency preparedness and response, and that there's a history of including provisions like this in the past. And so we feel like there's a good chance that we can successfully do this. And we have a broad coalition. Certainly, many organizations are interested in seeing this happen. And we have a sign-on letter that we would love to just pop into the chat. And the bill is the Pasteur Act, and we can put that information in the chat as well. And our sign-on letter, I'll just mention a few of the groups in the coalition: IDSA, Bio, Pew Charitable Trust, the Cystic Fibrosis Foundation, Partnership to Fight Infectious Disease, and 100 more organizations, all coming together to say that this is a good idea and needs to happen this year.
Thanks, Eli. So were you saying that it has not yet been introduced in this Congress? And who will be the leaders, are you thinking right now, on both sides of the aisle?
I'm not sure we're quite ready to say that yet, but
Okay.
But Amanda's off mute, so if she wants to say anything, she can certainly do that.
Okay, but it has not been introduced yet.
Has not been introduced yet.
And in terms of the leads, I can say that Senator Bennett and Senator Young introduced the bill last Congress, and they will be coming back to reintroduce it this Congress. And Representative Ferguson in the House was the Republican lead last Congress and will be in that role again. Representative Mike Doyle was the Democratic lead on the House side previously. He, of course, is no longer in Congress, but I expect that we'll be able to announce a new Democratic lead very soon.
Terrific. So I wanted to ask, there are a number of programs that the PASTOR Act would complement, so existing federal programs that address AMR, ways of tracking infections, et cetera. Lisa, can you talk about what progress has been made, putting aside the rollback during COVID, what progress have we made in addressing AMR through those existing programs?
Sure, happy to do so. Really sort of just a little bit of background starting in FY16. I think the noise level in terms of the importance of AMR rose to the level that there was the establishment of a national action plan to address AMR, which was wonderful. And so one of the things that happened was the establishment of several programs and sort of a more cohesive approach across not only HHS programs, but across AG, the State Department, USAID, to really comprehensively combat antimicrobial resistance. Within HHS, there are several key programs, starting at the Centers for Disease Control and Prevention. One of the new programs created was the Antibiotic Resistance Solutions Initiative, which is really the cornerstone of efforts to provide state, local, territorial health departments with key tools, money for labs, lab networks to do better surveillance on the local level of drug-resistant pathogens running through communities, additional monies for the kind of antibiotic stewardship resources that we've been talking about. That program really is the foundation upon which the federal government builds its AMR activities in terms of prevention and surveillance. There are several other programs at CDC that complement that work and work with the Antibiotic Resistance Solutions Initiative, including the National Healthcare Safety Network, which really and I think that Eli might have mentioned this earlier, sort of ramped up its visibility during COVID. A lot of the work that they do in terms of AMR is to track antibiotic use and rates of resistance, again, in healthcare settings, and then hospitals and other healthcare settings, including nursing homes, report that data back up to CDC so they can get a more comprehensive view of what's going on.
Thank you.
Yeah.
Oh, no, go ahead. Sorry.
I could go on and on. There are so many programs, thankfully, and those programs were making progress. But COVID, definitely provided a challenge, and now it's, I think, up to us to do the advocacy work necessary to provide additional resources so that we can get back to making further progress.
Thanks, Lisa. Your mention of surveillance and the National Healthcare Safety Network brings up the issue of diagnostic testing. And for our audience, this will be my last question, and then we'll go to yours because we do have a number. But diagnostics play a really critical role, right? In terms of, well, I'm going to have you tell the audience why. And also, how does the Pasteur Act address the need for new diagnostics and diagnostics to keep up with changes in antibiotic use? So who wants to take the diagnostic question?
I can speak to that one.
Okay.
So essentially, diagnostic tests are very important for surveillance, for helping to keep track of resistance levels and trends in resistance. They're also very important for individual patient clinical decision-making in terms of guiding whether or not to use an antimicrobial drug, and if so, which one to use, what drugs an infection will be susceptible to, all of that. There has been, I think, very important progress in the field of diagnostics in recent years that has definitely helped our fight against AMR, but we can't take our foot off the gas. We need to continue, keeping pace with diagnostic development in order to keep pace with emerging resistance threats. The Pasteur Act, I think, is important because it helps build more of those bridges between pharmaceutical companies that are going to be developing the new antibiotics and the diagnostics companies to make sure that they're working together, so that when a new antibiotic does come to market, there's the ability right away to do testing to determine what infections will be susceptible or resistant to that new antibiotic. The one other thing that I would add is that the tools themselves are only as useful as the experts on the ground who know how to use them. And that healthcare workforce, particularly that workforce with expertise in infectious diseases, in infection prevention, in clinical microbiology, that workforce is in just as big of a crisis as the antibiotics market itself.
Okay. Well, perhaps we can return to that and what IDSA is doing to, bring people into the fold. But I'm going to ask my colleague Jacqueline LaGoy to come on and ask some of our audience questions. Jacqueline.
Thanks, Jenny. Thank you, Amanda, Lisa, and Eli for this discussion. It's been really interesting and informative. So the first question from the audience, what are promising research directions currently?
It's almost hard to answer this question because there isn't enough research. There are fewer than 50 novel antibiotics in any stage of clinical development right now, and only a small proportion of those will actually have activity against the gram-negative infections. I think that scientists believe that there is a lot more that we can do, but we need that economic investment in order to really fuel that research.
Great, thank you.
Sorry to be gloom and doom.
That was great. Second question, does AMR worsen disparities in clinical care?
It unfortunately does. The CDC has started doing a little bit more research on this, which is wonderful. And yes, AMR does have a disproportionate impact on certain communities, and that varies in terms of risk of exposure, susceptibility to infection, treatment received. And so, I think, hopefully, as we move forward and there's more research done, we can find out more, but unfortunately, there is a disproportionate impact.
Thank you. Okay, next question. In terms of looking at novel ways to fund new antimicrobials, is there potential to apply this form of financing to other small market medical products? Are there partnerships or opportunities with groups supporting rare diseases?
There are definitely organizations that work on other rare diseases that have been supportive of, that are supportive of the Pasteur Act, and we greatly appreciate that. And I think that's because some of the antibiotic-resistant infections are rare diseases themselves. Some are not. And some other rare diseases can be impacted by secondary antibiotic-resistant infections. In terms of applying this to other market areas, I think our expertise is really within infectious disease. So I don't think I know enough to necessarily say that this model would fit for other disease areas, but potentially it could.
Great. Thank you. Next question. Are there any trends in resistance that you can speak to? Are there certain types of microbes that are more affected?
I think resistance in general, the trend is that it's going up. And that's true, I think, very much across the board. If we think about what are the pathogens we're most concerned about, both WHO and CDC WHO has a priority pathogens list, and it's specifically looking at pathogens where we need new development of new therapeutics. CDC has an antibiotic resistance threat list that is really based in epidemiology, looking at sort of where threats are growing, what's causing the most harm. There's definitely a fair amount of overlap and agreement between the WHO and CDC, which I think is helpful. And I would say within bacteria, the gram-negative bacteria tend to be the ones that are most highly resistant, most difficult to treat, and where we have the greatest unmet needs.
Thank you.
Jacqueline, I think we have some additional audience questions.
We do. We have a lot coming in. The next one. The Pasteur Act does not address the quality of antibiotics, nor does it require drug manufacturers to show that their products are more effective than what is currently on the market. How would you recommend the bill be improved to ensure the drugs produced under the contracts are truly beneficial for patients?
So I think this is actually a bit of a misunderstanding about Pasteur, which is I can appreciate, because I think Pasteur is a very novel approach. There isn't something quite like it. So I do think that it's on us to really do a better job of explaining exactly how this will work. But Pasteur will absolutely result in novel antibiotics that provide important clinical benefits for patients. That is infectious diseases doctors' top goal. We wouldn't support the bill if we were not confident it would result in that. And so specifically, to receive a contract under Pasteur, antimicrobials have to meet certain characteristics, including very explicitly improving clinical outcomes for patients with multi-drug resistant infections. And in addition to that, the drugs also need to be novel, and there would be an interagency committee advised by non-government experts sort of built into this bill that will develop a full list of infections for which drugs are needed, where there are unmet needs, and specifically any other characteristics that drugs need to meet in order to get one of these Pasteur-like contracts.
And if I could add to that, I think it goes back to the workforce issues, because the getting the drugs through the pipeline is only the first step. Of course, then you need the appropriate healthcare professionals to make those decisions at the other end. And there's nothing that we're less in favor of than indiscriminate use of antibiotics. So you need those professionals making those decisions. Just because you have new drugs coming out through that pipeline, you need the workforce there also to make sure that they're used properly and when they should be used, and not for patients that they shouldn't be used for.
Great, thank you. All right, next question. Regarding the Pasteur Act, is the legislation focused on incentivizing antibiotics applicable to one species of bacteria, or does it apply to more broadly? Does it apply more broadly to other therapeutics? For example, there are therapeutics in development that are host-directed that don't target a specific pathogen, but rather target the immune response to clear antibiotic-resistant pathogens.
So if it's a therapeutic that would help treat a multi-drug resistant infection for which there are currently unmet needs, it could be eligible under the Pasteur Act, regardless of the regardless of exactly the way in which the antibiotic works. And in fact, or I should say, regardless of the way in which the therapeutic works. And I would say if the therapeutic has a novel mechanism of action or is novel in some way, is different from the existing types of therapies that we have, then it would likely receive a higher level. That's one of the factors that would help it receive a higher level or a larger monetary contract under Pasteur.
We are getting a lot of audience questions, which is fabulous. I'm going to jump in and give Jacqueline a little break here. So two settings where we know there is great overuse in antibiotics are, I'm combining two questions. Outpatient, clinical care in the outpatient setting, and then also in the agricultural setting. So I'm sure there's a lot to say about how we address each, but perhaps you could take a stab at that. What will Pasteur address anything in the agricultural field? And then also, how do we, change clinical practice in the outpatient setting to reduce overprescription?
So Pasteur is focused on human health settings. We can't do everything in one bill. And also we do like to keep in mind, committee jurisdictions and just the challenges of moving bills through Congress. So it is a human health focused bill. But I think, you're absolutely right that we know that overuse of antibiotics in any setting, agriculture, the environment, human health, all of it contributes to resistance. So we absolutely need to be working on all of those fronts. And there are definitely efforts to improve our surveillance and data collection for antibiotics in agricultural settings, on farms, and so on, as well as to come up with more antibiotic alternatives so that individuals in those settings have other options of things that they can use that are not antibiotics, that are not going to contribute to resistance. In terms of the outpatient setting, I think, you're absolutely right. We know that there are high levels of antibiotic overuse. I think that some of the programs that Lisa talked about, like the Antibiotic Resistant Solutions Initiative, does provide support across the continuum of care in inpatient and outpatient settings. But what that program can do is limited by the amount of funding that it has. And so we're always trying to grow that pot. The other thing I would say is that in the inpatient setting, you have greater access to infectious diseases experts who are often the experts that are leading and guiding those antibiotic stewardship programs. And in outpatient settings, there's just less access to that kind of support because we don't have a large enough workforce to necessarily make all of those inroads, but building that stewardship infrastructure in the outpatient setting is absolutely an important need.
Great. Well, I think we have time for two more questions. Jacqueline, do you see one in the chat or the Q&A?
Let me take a look here. Yes. All right, here's one. Are there antimicrobial stewardship strategies or targeted interventions for stewardship programs, that actually have the potential to reduce the prevalence of resistance, essentially resetting bacterial resistance to its wild type as opposed to just preventing the development of new resistance?
Well, we are not physicians or scientists. We're policy folks. So I wish we had one of our antibiotic stewardship physicians on the line who could probably speak to that better than I can. But I will say, I think that the science of stewardship has advanced significantly over the last several years. A lot of that has been because of the resources that Congress has allocated to CDC to work in this area. And there has been a lot of documentation showing at a sort of overall general level that stewardship programs are effective in reducing resistance overall. Whether or not they're reducing resistance in exactly the way that this person is asking about is not something that I personally am familiar with, but we can certainly check in with some of our clinical experts and see if we can get more information on that.
Great. And I think your clinical experts are probably in a good position to address another question, which has to do with biofilms, something that I'm not familiar with. And this person is asking, is there adequate attention from the perspectives of the Pasteur Act and private sector funding for R&D of new drugs to both combat antibiotic resistant pathogens and their biofilms. So that may also be a question for your research folks.
Yeah, I can't speak to biofilms specifically, but I would say that, you know, right now without the Pasteur Act, there's absolutely nowhere near enough attention to supporting the antibiotic pipeline, but that we believe the Pasteur Act would be truly transformational on that front.
Well, this has been a terrific discussion. We've been following this issue and working on this issue for quite a while, and I learned a lot today. And we just thank you for all the work that you're doing. And all those who are joining us today, who are also working with you to really make a difference. So please don't give up, keep going. It's critically important. Before we end, 2 announcements. One, if you have ideas for speakers or topics, please put them in the chat. We're always looking for what is going to be of greatest interest and value to our Alliance members. And then next week at 2 p.m. on the 28th, we're going to have an off-the-record Alliance member-only meeting with Hill veteran Clay Alsbach, who is going to talk about implementation of the 2022 Inflation Reduction Act, or IRA, particularly on opportunities for how can the public engage and how can advocates engage in decisions that could potentially impact R&D. So a link to register is in the chat now. Thanks again for joining us today. Stay on for a few seconds and leave your suggestions for future programs. We appreciate your attention today and look forward to seeing you soon. And thank you for my IDSA colleagues. Thank you so much. Terrific job.
Thanks for having us.